supracondylar reverse flexion.
Just check out. Why did you say it was a supracondylar?
The patient had history of traumatic. The he was immobilized in plaster cast for 3.5 months. For 1 month in a slab and for 2.5 months.
There may be a language problem. The interpretation may be wrong. Tell me what finding. Why do you say this is marked supracondylar?
So on inspection, there is no abnormal bony prominences. 3-point bony relationship is maintained. On palpation, there is thickened supracondylar ridges on both the sides. And bony block felt widening flexion beyond 100 degrees. Range of motion is elbow is fixed till 60 degrees of flexion deformity with further range up to 100 degrees of flexion.
Okay, now tell me, is supracondylar fracture intra-articular or extra-articular?
So in this case, it is extra-articular because
In this case, in some cases it is intra-articular.
supracondylar fracture is extra-articular.
Always extra-articular. That is why it is called supracondylar. Normally, do you get stiffness as a complication or a sequelae of supracondylar? What is the commonest complication of a supracondylar fracture? What malleable?
Varus.
Humerus varus. So why are you saying that a stiff elbow is because of a supracondylar fracture?
So because on the bony relationship is maintained in intercondylar strength is not increased.
That makes it supracondylar
Basically,
fracture.
I think it is supracondylar fracture. I have to confirm it with the X-ray.
Why do you think so? That's what I'm here.
Why do you say there is a stiffness?
Because patient was immobilized for 3.5 months and
Well, what was the age of the patient when he had the fracture?
16 years.
16 years. And what is his age now? 18. So 2 years old. Continue. Sir.
What is the dominance? Is he right?
Right.
That also is specified. Normally, whether he's right and that sometimes will make a difference to your treatment. The thing is that it is also advisable to use the name of the patient. Even the short name, always mention the name because it is important. Sometimes in certain communities, as you know, that is a national pastime of massaging. Is there a history of massaging?
This patient has a history of massage and I also I would like to add one thing, he has wasting of arm and forearm.
Exactly. So because that also, because probably that is relevant in this case. In this case, if there is small injury, whether there is a fracture or not, if there is a contusion and some hematoma, if there is a history of massage, which many times patients come out with, then that can lead to some kind of problem. Because now retrospectively, if you see if there is a stiffness, then you can see that there is a myositis, which is very commonly seen in everyone.
So do you want to qualify your statement any further? Is it a case of myositis?
So it is a case of myositis with a matured myositis mass which is blocking the flexion.
So you think this is a mature myositis which is causing restriction of motion. The myositis is usually in the muscle. Which muscle is involved in this one? Elbow flexor. So if you have myositis in the elbow flexors, you will get a block to flexion or extension. What about extension? It's free.
Callus formation and in the polygonal fossa is also obliterated, which might also cause block the extension.
So what do you want to do for him?
So I would like to take plain X-ray of right elbow in anteroposterior and lateral close.
Can we put up X-ray?
Tuberculosis elbow.
So if there is any history leading to that, he doesn't have any history of joint pain before the trauma he had. He doesn't have any constitutional symptoms of fever.
Have you examined other joints?
I have examined shoulder and wrist joint and radial and
Wrist and right shoulder normal.
Yes.
wasting? Isn't it more than?
So there is 2 centimeter girth less in the arm and 1 centimeter girth less in the forearm, which is significant wasting of arm and forearm.
Do you explain this? Can you explain this only on the basis of this elbow or can it be something else?
There is no distal neurovascular deficit. It can be due to disuse atrophy of the muscles.
X-ray focus.
Projections. So post-traumatic elbow with bone is for blocking the elbow movements.
Okay. Otherwise, the X-ray is unremarkable. You can't see any fracture line. There seems to be a myocytic mass arising from brachialis probably, which has over 2 years remodeled. And he had ended up with residual stiffness. So the points to be learned from this case are: one, supracondylar fracture. Unless there is myositis or massage doesn't cause stiffness. It causes malunion. So whenever you are going to talk about post-traumatic stiff elbow, the commoner causes of stiffness are an intra-articular fracture or a lateral condyle or infection. You cannot have a supracondylar fracture giving you a stiff elbow unless there is myositis. So he got trapped initially because he said it was supracondylar myositis. Only when you were asked, can it be myositis, and Dr. Prabhu asked you about massage, you came up with that. You forget to omit the most important clinical point. Just a supracondylar, nobody will answer. Myositis, yes, can cause it. What are the stages of myositis?
So first is the hematoma stage, then there is technically inflammatory stage, and then it remodels and there is bone.
What is the time frame? What is the time frame of myositis?
So immediately post injury there will be hematoma swelling and signs of.
You call a myositis hot and cold. When is it hot?
So post injury 2 to 3 months.
And when is it cold? So it's in 3 phases. First 6 months, 6 months to 12 months, and 12 months to 18 months. First 6 months is when there is an acute inflammatory response and immature new bone formation. So you'll see flakes of immature bone coming from both sides away from the joint in the brachialis, in the earlier X-rays. Then you'll see it maturing and then resorbing. This is now 2 years past, it is resolved and there is just a block remaining. The importance of knowing this is that you cannot intervene when the myositis is hot. In the acute inflammatory stage, if you do any kind of surgical intervention, you are going to cause more bone formation. So any hot myositis will be warm, touch, and alkaline phosphatase may be raised. So you don't do any surgery during that.
At the same time, he has range of motion. His flexion, his supination progression is pain-free. When there is acute, when there is warm joint, all his movements will be painful. Okay, so he has about 30 to 40 degrees of motion, which is absolutely painless now. He has restriction of extension and flexion, but that is mechanical. So you must know that's why whenever you want to intervene, then the elbow has to be pain-free. At that time, if you need to do some kind of arthrolysis, that is the time. That in case we do that earlier, there is a possibility of myositis reform. So we will not achieve what we need to do.
So what you will offer it? Offer him arthrolysis?
So I will offer him arthrolysis because the myositis muscle is now mature. Posteriorly, sir, we go bilaterally, we go between the mobile guide, brachioradialis and the brachialis muscle.
So you are going to go laterally in the supine position, you take a lateral insert. Then do what? Tell me the steps of the procedure.
So we disconnect the superficial and deep fissure, then and the mobile guide of muscles will go posterior to that between mobile guide and the triceps to work the bony block into the ligament fossa, and then anteriorly between brachioradialis and the brachialis muscle.
What about intra-articular? a stiff position, do you think there will be adhesion inside the joint also? Or you're just going to take off the block and come out? That's it.
So after taking out the block, we'll assess the range of motion intraoperatively if it is in the functional range. If it is not, then we'll open the capsule and
How much do you expect to improve? How much range of
What
motion?
do you
Are you going to tell him that you're going to have full movement?
he won't have a full movement, sir. We can assure him 20 to 30 degrees increase in the range of motion.
Actually, if you remove the bone flap anteriorly, there is no reason why I should not be able to get the extension. Flexion also.
What is the conventional method of arthrolysis? Is it through a lateral incision?
It is the posterior midline, sir.
And what do you do? There are two ways of doing an arthrolysis. One is through a collateral approach, where you take two incisions medially and laterally and approach from both sides. And you are supposed to preserve the collateral ligaments and practically dislocate the elbow. There are people who will also do a medial epicondylectomy with the collateral attached, which is reattached later with a screw. So you can do a medial approach, dissect out the medial ulnar nerve, and then do a epicondylectomy with the collateral attached to it. Once you take that off, you can free the elbow, practically dislocate it and free from all sides. Take away the intra-articular adhesions, take away any loose pieces of cartilage, take away the fibrosis, shave off the anterior bump, shave off the posterior bump, put it back. And secure fixation with a screw and immediate mobilization. Unless you do immediate mobilization, you are not going to get a range of movement. So if you don't stabilize securely, you can't achieve the goal of arthrolysis. Okay, that is one. Second issue is when you do a collateral approach, there are people from the eastern part of India. So can you tell some name?
Famous name.
Some
Arthrolysis.
Bhattacharya, Bakshi. They have described, Bakshi has described the hinge elbow prosthesis, but Bhattacharya's method, I think, of arthrolysis, his philosophy was to instill steroid. They used to instill steroid intra-articularly every week for about 3 weeks post-surgery to prevent that inflammatory response which is there and start on CPM, early range of mobilization. Then there are centers who have designed their own upper limb CPM machines, which you should know about. So continuous passive motion using a upper limb CPM also people do. I think in Miraj they have an upper limb CPM because GS people keeps on talking about it. So they can use the CPM. The next method, do you know any other method where you can give a range? What is distraction arthrolysis? Distraction arthrolysis essentially is not for this situation. An intra-articular adhesions, once you do a capsulectomy and debride the joint, in cases of rheumatoid or maybe post-infective situations, where you do arthrolysis, you use a ring fixator with a hinge to keep the elbow distracted. And every week you change the angle. So instrumented distraction to create a gap and create fibrocartilage over a period of time. We use the distraction method to give some range in a therapy. These are the various methods for arthrolysis that you should be aware of. Post-operatively, when you finish your surgery, is there some medicine you want to give the patient? So what are the ways of preventing myositis from rehappening?
So NSAIDs and postoperative irradiation.
Specifically, indomethacin. And
Radiation therapy, postoperative irradiation.
how much radiation you will give? Dose.
What is the
Anybody?
unit? What we call it?
Centigrade.
Centigrade. Anybody knows